Much for this presentation. I'm going to be talking about Hodgkin lymphoma and specifically 5 options in patient management. As we start to talk a little bit about the pathology of Hodgkin, and the reason this is critical is many of the drugs that we're going to be talking about target some of the unique pathophysiology of patients with Hodgkin lymphoma. So shown in the top left, you can see 2 arrows pointing to the malignant cell that is present in Hodgkin lymphoma, a Reed-Sternberg cell. And the importance for this slide is the fact that it shows a paucity, just a small percentage, usually 3 to 5% of the malignant cells are actually present in the tumor. And the vast majority, as shown in the top right, is actually the normal physiology and normal cells that have been recruited to the tumor microenvironment. And shown in the top left is again a Reed-Sternberg cell with the unique owl eye appearance, but many of the cells around it are lymphocytes and histiocytes, plasma cells, B cells, other cells recruited to the environment by the malignant B cells that make a lot of cytokines. Shown on the bottom left is expression of CD30. And again, what is very unique about Hodgkin lymphoma is that the Reed-Sternberg cell expresses high levels of CD30. And as we'll be talking about later, brentuximab vedotin is an antibody drug conjugate that specifically will target CD30, and hence that makes this stain. Shown on the bottom right is overexpression of PD-L1 and bottom, and that's because of copy number gain and amplification of chromosome 9p24.1 as shown in the top 2 panels. And that is a very common occurrence in the vast majority of Hodgkin patients, resulting in overexpression of PD-L1 or PD-L2. This then interacts with PD-1 expression. And the reason this is highly relevant is that we'll talk a lot about PD-1 blockade, specifically the use of PD-1 antibodies, including nivolumab and pembrolizumab, and other new agents that are becoming available for treatment of patients. I want to just highlight for a second some important factors that are associated with our treatment management. So specifically, what we want to talk about is the concept of limited stage patients and advanced stage patients. Limited stage meaning that the disease is located only on one side of the diaphragm, advanced stage patients where the disease is on both sides of the diaphragm. And that's really important because limited stage patients commonly are managed with a combined modality approach, including combination chemotherapy and radiation treatment. In contrast, patients with advanced stage disease are treated with combination chemotherapy and omitting radiation treatment. The second important concept is the issue of favorable and unfavorable disease based on prognostic factors. And this slide here highlights a patient with a limited stage disease. You can see the disease located in the chest, but importantly, factors including the number of nodal sites, the size of the disease mass, the histology, the age, the presence of extranodal extension are all prognostic factors that would constitute unfavorable disease. The reason that is important is the number of rounds of chemotherapy may be more, the dose of radiation may be greater if you have unfavorable factors. This highlights advanced stage disease, and again, you can see on the PET scan, this patient now has extensive disease. There is disease on both sides of the diaphragm. There's also disease in both the liver and the spleen and bone involvement. Here, the prognostic factors are different, and you can see them highlighted here, being older, having advanced stage, including stage 4 disease, being male, and then a number of biochemical parameters are all associated with a poor prognosis. And what's important also to know, and we'll touch on this in a minute, is that PET scan results after treatment, after 2 cycles, for example, can really define whether patients can have less or more treatment, and is obviously a significant prognostic factor. The important thing, though, is to think about a patient in the concept of an early stage patient with or without favorable factors and advanced stage disease. This just highlights, as we start to talk now about novel therapies, primary treatment, what we would typically think about how to manage patients based on what I just told you. So if you have an early stage patient with favorable disease factors. And here again, the number of sites of disease is really limited. You can give 2 cycles of standard ABVD chemotherapy plus 20 gray of involved field radiation therapy, and that would be a standard treatment. If you have unfavorable factors, you would give more chemotherapy, typically 4 cycles of treatment, and you would give more radiation, typically 30 centigrade of radiation. We'll talk about this in a minute, but early stage patients can also be managed based on PET scans, where if you've had 3 cycles of treatment and a negative PET scan, the radiation treatment can be omitted with only a modest impact on progression-free survival. In advanced stage patients, combination chemotherapy is usually the standard, radiation treatment is not commonly given, and the use of new agents, as we'll discuss extensively in a minute, including brentuximab vedotin, or the use of nivolumab, or a more aggressive chemotherapy kind of approach, such as the use of escalated BIACOP, now sometimes with additional novel agents, including brentuximab added, is really the standard of treatment therapy. So taking us now back for a second to relations and talking about how we really want to move forward and build on what we've been doing in the past, which included chemotherapy plus radiation treatment. And the RAPID trial was really a focus on whether or not radiation therapy could be omitted. And what's important to see here is on the right, or firstly on the left, is the intention to treat analysis where radiation therapy was compared to no further treatment. And on the right, the per protocol analysis. And what's important to see is that if patients had 3 cycles of ABVD chemotherapy, had an excellent PET scan, and were not given a the decrement or decrease in outcome was pretty modest, and therefore I think a large percentage of the treating physicians felt that you can omit radiation treatment in limited stage patients who respond well to treatment based on their PET scan, and radiation treatment may not be needed. That became, again, one of the standards that we really need to compare all of the data I'm about to show you, compare it to those data. However, a word of caution. These are data from our institution in 2016 when the RAPID trial results were available. We made a practice change where we began to omit radiation therapy from everybody, provided their PET scan was negative and they had limited stage disease. And then we went back and reanalyzed our data last 2 years ago. Important to see here is that actually patients receiving chemotherapy alone without radiation treatment actually had a substantially worse outcome than those that received combination treatment, which had been our standard before 2016. And the cautionary note here is that we did not exactly follow all of the criteria within the RAPID trial, meaning that sometimes patients had more bulky disease, sometimes patients had worse prognostic factors, and we still followed that approach. So this is just a cautionary note and sets us up for why novel therapies are required as we think about new strategies moving forward. So this is now talking about what we could do, but still maintain the good outcomes that are seen with combined modality therapy. Now, this is data that was presented at ASH a year ago, where a study of 83 patients utilized the similar approach of now incorporating brentuximab vedotin plus chemotherapy. A PET scan was then done with just nivolumab was offered if the patients were PET negative. If PET positive, both brentuximab vedotin and nivolumab were given as consolidation. I think the important thing to see is that the vast majority of patients had an excellent response. Only 2 patients required radiation treatment, and progression-free survival after consolidation with nivolumab in the patients that had a PET negative result was 100% with longer-term follow-up. So just to say, as new agents are brought into the combination, you can actually more safely remove radiation therapy and maintain excellent results. And these data were confirmed by additional study. This is the study from the German Hodgkin lymphoma study group. In this trial, there was a utilization of nivolumab either in a sequential or in a concomitant kind of approach. This was specifically in patients with limited stage disease but unfavorable characteristics. And you can see that, again, while patients did receive consolidation radiation therapy, the results were actually outstanding. And if one looks at the longer term outcome, most patients had an excellent response to treatment, and this was then maintained. Now we're looking at, could we bring these novel agents in patient treatment of early stage patients and really, again, omit the radiation therapy and leave out drugs that may actually even give more toxicity. So this is a combination approach presented at the most recent ASH meeting using brentuximab vedotin plus nivolumab, now only with doxorubicin and dacarbazine chemotherapy. And you can see that in this trial of 154 patients, outstanding results were seen, well-tolerated treatment with a very durable benefit for patients overall and a very high response rate. So the messages here are that as new therapies are brought to bear on patients with early stage, particularly those with unfavorable characteristics, the outcome for patients is looking really excellent. Now we're going to change gears and talk about advanced stage. I think we need to just refer back to RATHL trial. And this was, again, a strategy looking at, can we limit toxicities while maintaining benefit? And in this study, if patients were treated with 2 cycles of standard ABVD chemotherapy, for those patients who were PET negative, the bleomycin, which has always been a very toxic drug with significant pulmonary complications, was omitted in the one arm or maintained in the second arm, and 6 cycles of treatment were completed. If patients were PET positive, however, those patients' treatment was escalated by intensifying treatment to an escalated BIACOP or a BIACOP 14 approach. The important thing, I think, to take away here is that, again, using the PET scan as the prognostic indicator, negative PET scan patients had an outstanding result and bleomycin could safely be omitted. So that was kind of a standard approach for us to be thinking about as we compare novel drugs to this treatment strategy. Data then looked at the use of brentuximab vedotin, replacing bleomycin in the combination. And as you can see on the top left, the progression-free survival was significantly improved with the use of brentuximab vedotin plus AVD chemotherapy over ABVD chemotherapy in advanced stage patients. And with 6 years of follow-up, as shown on the bottom right, the overall survival was actually improved. The first time actually overall survival was impacted with treatment for Hodgkin lymphoma. This has then also been tested in the, if you like. So BIACOP was made to a treatment known as BRIA-CAD, and that BRIA-CAD was then compared in a randomized study to escalated BIACOP. And data that was presented last year in a very large trial showed that really the outcomes with BRIA-CAD were as good, if not better, than patients who received escalated BIACOP. But importantly here, the drug combination with BRIA-CAD was better tolerated with fewer in the way of side effects and long-term complications, really establishing the addition of brentuximab vedotin to a modified BIACOP regimen as a standard in the German Hodgkin lymphoma study group setting. Further new drugs have been applied in advanced stage patients, and this was a small study of 51 patients looking at the addition of nivolumab plus AVD chemotherapy, and you can see here the results in the initial study were very promising. Treatment was well tolerated. The progression-free survival, although the follow-up was short, was still excellent. And this then led to a combination strategy approach where the combination of nivolumab AVD chemotherapy that I just described and the brentuximab AVD chemotherapy that had become a standard, as I also described, were then compared head to head. So everybody here had advanced stage disease. Everybody here got 6 cycles of treatment. And this data was presented last year, really encouraging results where nivolumab AVD chemotherapy showed an improvement in progression-free survival when compared to brentuximab vedotin AVD chemotherapy, and also with excellent tolerability and less in the way of peripheral neuropathy. Data that was presented at the most recent ASH meeting that was really important showed that these results, when we looked at the different ends of the spectrum, specifically elderly patients or very young patients, held up very substantially. You can see here, this is for the elderly patients, those over 60, and you can see that the use of nivolumab AVD chemotherapy compared to brentuximab AVD chemotherapy was substantially better. This is the data shown for the younger patients. This is those younger, and you can see again that nivolumab AVD chemotherapy shows a improvement in the progression-free survival compared to the brentuximab AVD chemotherapy. So all told, I think the important message in advanced stage patients is that the use of novel agents has improved the outcome over standard chemotherapy. And as we've moved to now to PD-1 blockade, less in the way of toxicities and side effects. Data now looking at, can we further improve the toxicity profile? In limited stage patients, the use of brentuximab plus nivolumab, then only with doxorubicin and dacarbazine, and that showed really good results. This is similar matching data in advanced stage patients, and you can see these results look outstanding. However, this will need to be compared against, for example, nivolumab AVD chemotherapy to show that it is truly better. So with the data that I just showed you, really confirming that in limited stage and then in advanced stage patients, the use of novel agents has really impacted the outcome. Are we seeing similar results as we move into patients that have relapsed after frontline therapy? So here you're seeing data utilizing the first salvage setting, and this is pembrolizumab plus GVD chemotherapy. These are data from a year or two ago, small study, but the most encouraging and interesting thing from this data is a very high overall response rate, a complete response rate of 95%. And importantly, the majority of these patients went to transplant, and the vast majority of them in a complete remission. Results from this data show that with longer-term follow-up, these patients are doing very well, suggesting that the use of a PD-1 blocking antibody in this combination is highly valuable, particularly for patients going to transplant. These are very similar data now using nivolumab chemotherapy, and the important thing here again is that you can see the overall response rate very high, response to a complete response rate, the vast majority of patients able to go on to an autologous stem cell transplant. And in this study, not everybody required chemotherapy. Some patients could go to transplant having just received a PD-1 blocking antibody. And with 2 years of follow-up, progression-free survival and overall survival looking really good. So again, principle being that utilizing PD-1 blockade in the salvage setting results in excellent outcomes. And these data were then looked at a real-world level, and this was data just presented at the recent ASH meeting. Looking here, you can see the blue line as patients who received a checkpoint inhibitor as part of salvage therapy before going to transplant, compared to those that received chemotherapy or a brentuximab-only containing approach. And you can see that adding a checkpoint really seems to make a substantial difference. Now, with that said, again, just to highlight the use of novel agents in frontline, the use of novel agents in first salvage prior to transplant, what are we going to do in patients who subsequently may relapse post-transplant? And I really just want to highlight a few strategies that are now entirely different, but are showing real promise. The first is utilizing a CAR T-cell approach, which is very similar to what's done in large cell lymphoma. And this was data. The challenge with here is the durability of benefit, where some patients will subsequently relapse, and we would like to see a plateau in the PFS curve over time. Maybe using an additional checkpoint may make a big difference. So data here presented at ASH very recently is the use of an anti-LAG3. This is a different checkpoint to PD-1, which is a checkpoint, as most people will know. In this case, patients had received PD-1 blockade and then received the anti-LAG antibody. And you can see an overall response rate here that looked quite promising at about 30% of patients. But I think, as you can see from the waterfall plot, actually the majority of patients having some benefit from this approach. So could we bring new checkpoints? Could we apply CAR T cells? These are all looking quite promising as therapies for patients who relapse post-transplant. And the final strategy is to utilize bispecific antibodies. This is a novel strategy here where NK cells from cord blood were taken pre-coated or pre-treated with AFM13, which is a bispecific that targets CD30 and CD16, and then administered to patients. And you can see here overall response rates and complete response rates that were very high. And challenge might be is the durability of benefit here was still short. But you can see from the waterfall plot in patients that had received a lot of treatment, the outcomes actually looked outstanding. So to conclude, what are the new options for managing Hodgkin lymphoma? I think you've heard me say multiple times now, using new agents, brentuximab vedotin being one, but particularly highlighting the value of PD-1 blocking antibody to initial therapy is very valuable. Adding PD-1 antibodies to salvage therapy, particularly patients going to transplant, appears to improve their outcome. And then utilizing these novel agents, CAR T cells, bispecific antibodies, and new checkpoints in clinical trials will allow us to understand how to manage patients who have failed post-transplant. For your time and attention, and appreciate in this meeting.
Dr. Ansel, lots of have a lot of questions. So the first one, special food regimen prevent relapse in Hodgkin.
That's a good question. No, because it would be great, something you could take. However, the important thing is diet, keeping patients able to tolerate a specific sort of diet that you got at present.
Based on one side of both, but it's classified as late stage, define and treat stage.
So firstly, just to say, the reason for are really is just, as you know, trials, the intergroup brentuximab AVD stage 3 and 4. He is a little bit of a throwback before we really had good ways of PET scans, and often some suspicious for more years. But to answer the really appropriate, I would always say treat in the more aggressive fashion to more advanced stage if there are any questions in the management.
So if you have a patient with limited stage, unfavorable features, bulky disease more than 10 centimeters, but this patient is PET negative after 3 cycles, what is your approach, novel agents or radiation therapy?
So I would say I would still be in favor of adding in radiation therapy. And the reason for that is that we actually did a retrospective review of our patients managed in the same as the RAPID trial. And we actually found that the RAPID trial had looked at patients not with bulky disease, with more limited stage disease. But as we liberalized our sense of we can do that for bulky patients, our outcomes were worse. So in my view, if you have a patient with bulky disease, you need to make a decision right at the beginning and not entirely be PET directed. And we would still favor including radiation in those patients.
NCCN guidelines still consider using only single agents for a Hodgkin's relapse over the age of 60. Is that what you would do, or what is your approach for such a patient?
So I think in principle, what you're looking for there is if you are choosing to say you cannot go for curative therapy anymore, that then you're looking for a palliative approach and you want to use each agent to get the maximum benefit you can. Quite frankly, 60, as I'm approaching that age myself, I still want to be considered for curative therapy. So if you feel the patient could still be managed with a more aggressive approach in an autologous transplant, I think that is still the direction you should go. I also think that if you have a patient who has a lot of symptoms and you need rapid disease control, there is merit to considering a combination strategy. But when you're looking at ways to really maximize benefit in an old, frail patient where toxicity is a concern, utilizing single agents as per the NCCN guidelines is appropriate.
If you have a patient with advanced stage but low IPI, do we ever use single agent pembro or nivolumab?
Particularly in the front line, the goal is always to cure patients. So I think we have to be very careful that as we minimize therapy, we don't lose the curative potential of treatment. If we look at elderly patients treated just with brentuximab vedotin and PD-1 blockade as frontline, while response rates were high, the relapse rate remained high. So I am always very cautious not to limit therapy too much and then end up failing to have the curative potential that many of these regimens bring.
So you discussed the nivolumab ABVD upfront therapy for advanced stage. Is this in any subset of advanced approved by the FDA or not yet?
Not yet, but many people find and get approved ABVD chemotherapy. So then I think it's a very reason. In my practice, try it as my preferred treatment, brentuximab vedotin, and so UD is actually potentially in those group of patients.
Of Nivo over PAM, can you use both together, efficacy?
I personally, in using them together, much are very equivalent. And so you heard me say equivalent therapies are very similar, and pembro or nivo for me limit, and I don't think there's a one versus the other. In general, data, so study use prefer pembrolizumab at the study of nivolumab.
And use of checkpoint inhibitor, do you also use them in the salvage setting? Would you with transplant?
Good. Right now this is becoming complicated to look at what we did in frontline. They use subsequently. If progresses on a inhibitor, I do not think there is merit as the next line. Really benefited and relapsed, then I think there's value in doing a post-transplant consolidation. Right now the data is really brentuximab vedotin, PD-1 blockade, and see brentuximab, they should.
And your last two slides are exciting. You discussed the and AFMs. Just give us, how do they work in future development?
Yes, reason for targeting that is that Sternberg cells are LAG3. Really, that's another checkpoint that would be very valuable. 13, which targets CD16, so basically brings proximity, really CAR T cell or CAR. That's why it's very exciting and interesting.
Very much, Dr.